They're having a party out there. Okay, so where we got to yesterday was the baby's out, the cord is cut. We have 2 patients, and that's where we're going to take off now. We have 2 patients. And if you weren't here yesterday, you did miss a lot of material, but you can catch up. Maybe you've read your chapter, I hope. And we mentioned an assessment on a neonate. Neonate means newborn. Let's get that clarified first. There's neonate, there's infant, there's toddler, there's preschooler, there's adolescent, there's a whole bunch of names under the big umbrella of pediatrics, and that's our next chapter is pediatrics. But right now we're at the neonatal stage. So neonate means newly born. And we assess neonates a little bit different than we would assess an adult. You can't talk to them. You can't ask them a sample history. They have not had a history. This is a brand new person. It's a brand new assessment. So we have to develop or at least they developed a technique to do it, and it's called the APGAR scoring system. So APGAR is an assessment. It's an assessment that we use for the newly born. This APGAR scoring only lasts up till 5 minutes of life. After 5 minutes of life, we don't use it anymore. So we do it at 1 minute and 5 minutes. That first minute of life, if you want to call it the golden minute, you can. In that first minute is when we're going to make this scoring. I'll show you the APGAR scoring chart here in just a second on how to do it. But I want you to get in the mindset of, I have a new human being here that has only had a few breaths, if any. We hope it's had some, but it may have none yet. It hasn't even taken its first breath, maybe. And I'm starting an assessment on it. I'm starting an assessment for the rest of its life. Maybe that's why we don't like OB. Maybe the delivery of the baby is one thing. Maybe it's now I've got to do something else. Now you're in a hospital setting. We have the ability to take that baby and run it over to pediatrics, and pediatrics can work this child and resuscitate this child and take care of this child. And then we're still left with the nursing and medical team for the mom. And then the ambulance, that gets very limited. It may just be you by yourself. And you're having to shift gears so fast and go from delivery, mom complications, to now I've got a baby that's blue, not breathing, and I need to resuscitate it. That's quite a challenge. I told you a real life story that happened within 48 hours of a woman, a nurse I talked to yesterday who's in pediatrics. Those of you who have missed, you didn't hear this story. Baby in the bed. EMS brought the mom in. Baby was delivered upon transfer from the cot to the hospital bed. They called pediatrics in there because we have a baby. They had a baby. The pediatric nurse clamped and cut the cord and took the baby over to their area for resuscitation while mom was trying to be resuscitated from methamphetamines. Let's just give it a 10-minute window. If the transport had been 10 minutes longer, who would have taken care of all of that? That paramedic by him or herself in the ambulance. One train, one traffic delay, living out, picking that patient up 10 minutes further away from where they did, that would all been on you. And quite the challenge that is. So if you want to know why this chapter is relatively long and there's a lot of information and it's a subskill on the registry, it's for those reasons. The number one thing we have to start doing immediately is drying and warming. And I think those should become almost simultaneous. When we're drying the infant, we're also warming the infant. We already know we can lose heat through evaporation, so we need to get the wetness off of the baby. So we dry it, and once our towel or our blanket becomes saturated, let's get a new one. And it's really nice if those blankets were warm or those towels were warm before you were drying them. So back in the delivery process, knowing you're going to have to dry an infant, wouldn't you like to get your towels on top of the defroster in the ambulance or in front of the heater? Some way to warm those towels. Some ambulances have devices that will heat and cool meds. So if you know you're going to deliver, get those towels kind of started up. If you're in a home delivery, you're going to swaddle that baby, there's nothing wrong with throwing that blanket in the dryer and getting it warm that towel in the dryer before you do it. Now your OB kit's going to have some towels, but it's not going to have the towels for the baby. This old adage of send the dad out to boil water and get towels, there may be something to it other than just getting rid of him. Maybe we do need those warm blankets when we come back. The ambulance, if you're in an ambulance environment, even in summertime, you should be running the heat. It should be uncomfortable to you. And then tactile stimulation is not hang them by their feet and slap them on the butt. Tactile stimulation is not a sternal rub. We don't need to do sternal rubs on people. It's just, taps. Just, hey, hey, hey. If you want to say, hey, baby, you okay? They're not going to understand it, but you can say it if it makes you feel better. The bottom of the feet, rub vigorously. That's what we mean by tactile stimulation. No slapping, no pinching. I don't think anyone would do that, but you might have seen it in the movies. Suction if needed. Suction if needed. We used to suction routinely. Now we suction if needed. Can anyone tell me the complication of suctioning a neonate? What's the problem with it? Huh? Okay, he's trying to breathe and I'm taking stuff out. Yeah, that's not good, is it? That's not good. There is some tactile stimulation to probing the mouth and the nose with the little bulb syringe. There is some. Make them sneeze. Make them irritated and maybe they'll cry. We want them to cry. I know that sounds bad, but we want them to cry. What's the other danger? You're right, we're sucking out air that we want to go in. What's the other danger of it? Or complication? Especially if we get overly aggressive.
So small and developed. Can it do something in the airway?
Okay, we got something in the airway we don't want in the airway.
There's like so small.
So small, underdeveloped. You're onto something there, James. It's occluding in itself. It's occluding in itself, right? If I'm trying to breathe through my nose and you stick something in my nose, that's an issue, or mouth. That small and underdeveloped makes them also have a highly sensitive vagus nerve. They're very, very sensitive on the vagus nerve. And where do we find the vagus nerve? Well, it starts at the brain, runs all the way to the anus, right? But in the process, it goes through the throat. So when you're probing the throat with that bulb syringe and you're hitting the back of the throat, you could stimulate the vagus nerve and now the heart rate's going to fall. So we're going to talk a lot about the heart rate falling, and this is twisted to what you would normally think. This is backwards from the adult in the aspect of a decreasing heart rate. I would say the number one cause of decreasing heart rate is hypothermia. They're cold. So if I've got a baby with a heart rate that's going down, they're probably cold. Now you need to know another piece of information. What's a low heart rate in a neonate? Oh, that's way low.
60.
That's way low. That's way low. Even that's low.
Oh, isn't it 60 or somewhere around that?
Yeah. We don't want a heart rate below 100 in a neonate. We want a heart rate 120, 130. That neonate's heart rate should be fast. Do you know where I'm going to check the pulse on the neonate?
Like the
Brachial artery. Yeah, the brachial artery. if I've got a dropping heart rate, I need to start just checking the basics first. Keep it simple, stupid. The KISS principle applies here. Is it cold in here?
No.
If it is, you need to fix that. I'm about to highlight something called the pediatric resuscitation, I'm just abbreviating, triangle. The pediatric resuscitation triangle or pyramid, and it's upside down. It's upside down, and you'll see why here in a minute. So step one, are they warm? Question mark, are they warm? You can add to that warmth, are they dry? Because they go hand in hand, don't they? I mean, I think for most of us to be warm would be dry unless we're sitting in a sauna or a hot tub.
What does the PRT mean?
Pediatric resuscitation triangle. And Gus, I don't mean to cause confusion. I promise you I do not. There is another triangle called the pediatric assessment triangle. I'll talk about that in my next lecture. The reason I'm using this one is it's so different from the adult. It's so different from the adult. If I was to show you an adult one, it would look like this. And this will make sense in a minute, so hang with me. Promise. I'll fill in the gaps. Just step one. Are they warm and dry? When the baby is born, his or her heart rate should be at least greater than 100. I like 120, maybe even 130. I'm not gonna dive off in the weeds on that, but if it's better than 100, then okay, I'm holding. I'm pretty much okay there. Some of you said 80, some of you said 60, some of you said 40. Yeah, that's when things are really serious, and I'm about to talk about it. Are they breathing? Question mark. Crying, a vigorous cry, I'm not counting respirations. How do I describe breathing in an infant, a neonate, who's vigorously crying, like just mad? I love that. That's what I want to hear. It's really hard to say, well, their breathing rate is 32 times per minute. I just need it to be fast. They need to be heart beating fast and breathing fast as compared to the adult. If they're not, go back to this question, are they warm and dry? Are they warm and dry? Have you overly suctioned? Do you see oxygen being mentioned yet? No, it's going to be down in here. Do you see drugs being mentioned yet, like on the paramedic level? That's down here. Let me show you the base of the triangle are the drugs. In paramedic school, there's a lot more detail to that triangle, but where are the drugs is the point here. Last resort. What's the first option? Warm and dry. Warm and dry. We don't do this until we find this, warm and dry. For comparison sake, an adult with cardiac issues, what's one of the first things we'll pull out of the box? The drugs. The drugs. That's why it's so much different here. We don't worry about an adult with a heart rate of 30 being warm and dry, do we? We look at an adult with a heart rate of 30 and go, I need ALS here so we can give them some drugs to raise their heart rate, epi or atropine or whatever the case may be. No, we don't do that in the pediatrics. We start with the very basic things. This is all happening within the first minute of life, and it's on you. As we go through this, we'll fill this in. So, they should begin breathing within 30 seconds after birth. They can go a little longer than you think they can. Your initial instinct would want them to be breathing immediately. If they're not breathing upon actually exiting the birth canal, note it, start your clock, but don't start freaking out immediately. It takes a little bit of time You're inflating alveoli that have never been inflated. You're clearing airway secretions that have been lying there for 9 months. This is a new engine you're starting up here. You got to have a break-in period, so to speak. Heart rate will be better than 100. If they're warm and dry and suctioned and stimulated and it's still there, oh, now we're filling in the next piece of this. Maybe we should breathe for them now. Okay? So I'm past this minute. The clock's been ticking. This is getting uncomfortable. My heart rate's not quite where I want it to be. My breathing rate's not quite where I want it to be. I've done what you've said do, Brandon. Warm, dry, tactile stimulation. What's my next step? Where do I turn next? Just give them a few puffs with a BVM. It's very small. It's very tiny. You got big hands, Luke. Don't squeeze the bag. Don't blow the lungs apart. These are new lungs. They're fresh lungs. They're tender lungs. Little puffs of air with the BVM. And it may only take 5 or 6 of those, and that's enough. You're not locking into the 6-second CPR for 35-minute kind of thing. We hope not. This is just a few puffs to kind of get things going. I did not say with oxygen. I did not say with oxygen. Is oxygen a drug? So it's going to come a little bit later. I can add oxygen to it, but I'm getting deep in the pyramid, if you will, before I add the oxygen. Oxygen is a little bit, maybe I should say a lot, toxic to the baby, especially the eyes. High concentrations of oxygen around a neonate's eyes could lead to blindness or eye damage. Be careful with oxygen around the neonate. I think you've learned so far in EMT school, and if you were able to go back in time and watch another EMT school, oxygen would be the golden miracle drug. Everybody needs it. Now you're learning that, no, hey, it's a drug. We need to use it with caution. So keep that in mind as we go through this. I can add the oxygen, but it's not my first call. It's not my first call. In the adult cardiac arrest, what's the first thing we do? Ventilate them with what? Oxygen, BVM, connect to oxygen. Yeah, because they're in cardiac arrest. We don't do that in the infant. We put it down here in this drug category. Are they breathing? Not very well. Give them a few puffs with the BVM and see what happens. Reassess. Now we're in that past 1 minute, going into the 5-minute assessment time frame here. This, if you put it in the pyramid fashion, is what I'm doing right here. That's what I'm doing right here. I am about to cross this threshold. Use a bag valve device to ventilate if needed. This is seldom required. If it is required, we hope it's just a few puffs and we can go on. If things go to bad from worse, ding, ding, heavy ding, ding, lots of questions right here on this statement. Perform chest compressions if there is no pulse or if the heart rate is less than 60 after 30 seconds of ventilating and the heart rate's not changing. I can't stress that bullet point enough. You need to know that bullet point. It is about right here. It's somewhere in this range of your triangle. We're still not to drugs. We are still not to drugs. Do I have an ALS unit on the way if I haven't already? It's not available. That would be nice, or I'm moving toward a facility. Where's mom? Where's mom in this? She could be right next to you on the cot, or she could be in another ambulance. I threw that in there because we're like so concentrating now on the newborn, we kind of forgot about her, didn't we? But she's still a patient. I can't abandon her. I'm taking her with me, or some other unit has her. if the heart rate falls less than 60, we start chest compressions. Another heavy bell ringing ding ding scenario. The chest compression to ventilation ratio is 3 to 1. Most CPR classes do not teach this. Most CPR classes that you go to are designed for somebody to be sitting in a gymnasium and somebody collapses and you go start CPR and get an AED. It's in the book. It's in the AHA Basic Life Support book, but it's buried off in kind of like the appendix. That's why you're in EMT school. You're better than that now. The ventilation to compression ratio of a neonate, the newly born, in this first 5-minute time frame, if chest compressions need performed, the ratio is 3 to 1. Give them 3 compressions and a breath. 3 compressions and a breath. Can anyone tell me why that ratio is the way it is? What's the significance of the 3 to 1? What are we gaining out of that?
More
Blood flow. But we get blood flow out of 5 to 1 or 15 to 2 as well.
You get faster breathing.
We get more breathing, don't we? We get more breathing per cycle. And that goes back to what is the most important thing on this baby, warm, dry, and breathing. When we study pediatrics in the next chapter, we'll see that the biggest problem with heart issues in the child is breathing issues. And that holds true here at the neonate as well. Heart rate less than 60, we will do chest compressions. Now they have a pulse. We're just adding to it. There's sometimes I want to say things and I'm afraid to say them because you may misinterpret them and miss it. At the same side of the coin, I'm like, if I don't say it and they hear it, they might misinterpret it and miss it. So listen carefully. Some people get this messed up and think that an adult with a heart rate less than 60 could benefit from chest compressions. I've heard some nurses say that. Some practicing nurses in ERs today, I have heard say that. This chest compressions, when the heart rate's less than 60, only applies to what? The pediatric, the kid, the neonate. It does not apply to the adult. It's been tried in the adult. There's been trials over it, but it's not an effective mechanism in the adult. And to Frank's point, I get a whole lot of breathing with this ratio. Don't expect, I hope, to have to do this for a really long period of time. This is just a few cycles and we hope this thing turns around and goes for the better. It's just kind of like, come on now, warm up, come on, get going, get your breathing established, get your heart rate established. I'm going to breathe for you very often and we hope it's going to climb out. We hope things are going to turn around relatively quick. I'm really looking at just a few cycles of this, nothing for 30 minutes of it. If it's going to turn around, it will pretty quick, okay? But I don't want you going here if they're wet, cold, got stuff in their airway, haven't been suctioned, haven't been tactically stimulated. You with me on that? Okay, let's say things are starting to look good right here. I'm turning the corner. The heart rate's picking up. The color is improving, blah, blah, blah. Do I just stop everything and say I'm good? No, I back out of it as well. So I may stop the chest compressions, but I'll still use the BVM. Things are still improving. Okay, let me pull off the BVM and just make sure the airway stays open and the airway stays clear. Okay, I'm still good. Okay, now I'm just back to making sure they stay warm and dry. Now maybe they can feed. Remember, they need to get that nourishment in them quickly. That warm milk, that warm colostrum, that caloric intake is just as important for all this to work as the oxygen is, if not more important. Yes?
And so what if the mom is like one of those where she doesn't want to breastfeed, like the, what's it called, the formula?
She needs to move back to Hollywood. Gus, that's a great question. If she's so diehard set on not breastfeeding, you got to go with those wishes, or she's on drugs, or she's not around, or something. We have that issue, and that's not good for the baby. And you may not be able to correct it pre-hospital, but it can't be good for the baby. I honestly feel like if a woman is honest with herself, most will be just open and honest to begin with, but even those that have this vanity issue, I don't want saggy boobies, so I'm not breastfeeding. If you're that self-centered, a lot of that's overridden when that oxytocin hits. I know a lot of women who say one thing before they're pregnant, or maybe even while they're pregnant, but upon delivery, they're a new person. Moms become moms real quick upon delivery. And those of you in the animal world know that, you know, mama dog will turn on you, mama cow will turn on you. That's the nicest person you'll ever meet, but you start messing with that baby and that baby's distressed, there's even more of an instinctual maternal give it to me. So we got two extremes there. We got a vanity extreme, or we have an extreme of, like Chas said, just not capable. Maybe, you know, you're down the road. The ambulance has the mother. The other ambulance has the mother. But I just need to stress to you that if we're backing out of this triangle, we could back completely off of it, and now we're just being normal mom feeding infant. Are you with me on that? Now, they don't put that in the book. They don't put that in the book. I guess you could say, once we got through this, you don't need me anymore. Things are going good now. Things are going well. Hunter, I pick on you because I know, you know, you mess with cows and stuff like that. If you got a calf that's born in the cold and he's not doing well, and you dry him off, you put him in the cab of the truck, what's your primary focus with that calf to get that calf well and healthy and off to a good start? You want him to suckle as quickly as possible. Because once that calf gets him a good few drinks of colostrum, it is amazing. You take something lifeless and now it's running across the field kicking its tail up in the air. It was the milk. It was the colostrum. That really high fat, rich, nutrient, warm, get into the gut lining of both that calf and the baby human. The gut lining and the intestine, it just pulls it directly in. It's full of antibodies. It's almost like blood in itself. It's so nourishing. It's so nourishing. It cannot be duplicated. They try to duplicate it, but it cannot be duplicated. And the quicker that's in the gut, the better it is. If you go to a NICU, a neonatal intensive care unit, once they get this baby out, and Gus, to your point, they can't breastfeed, they may use donor colostrum or an artificial colostrum, a man-made colostrum, and they'll put a feeding tube in that infant and get that nourishment into that infant immediately. All of what you see here takes calories. It takes calories. We haven't even begun to talk about a baby that's in a bad shape because it lost its sugar supply, it lost its methamphetamine supply, it lost its alcohol supply, its narcotic supply, and those babies are in bad shape. They seize, and you know, put that on top of this. You know, we're just kind of talking a baby that was born and got a little cold. It's kind of minor. It's an emergency, but it's not the critical thing that we could get into here. Any questions on the triangle as I have it written, or how that would apply to the triangle? We go deep into it. We could go all the way to drugs. That's beyond the scope of an EMT, but at the paramedic level, I could start little IVs, start little infusions of epinephrine. It's like, damn. And then maybe little drips of sugar if their blood sugar is too low. Maybe little doses of Narcan if they're so depressed because they're overdosed on narcotics. Those examples can't be fixed at your line. You know, if your line is right there, you can't fix it. So you go down deeper and you cross the ALS threshold, and then you get a paramedic there and you hope him or her can fix it. And then I just want this baby at a NICU capable hospital as quickly as possible. We just don't get a lot of experience intubating something that small. To get that experience, we'd probably have to go to a vet clinic and intubate cats and kittens. We just don't get a lot of experience putting really, really small needles into veins we can't see. Maybe we do it on the scalp or the sole of the foot or something. And I sure hate to get the needle out and drill into a little bone. But I can. I just don't get experience doing that. So my skill set diminishes in this because I just don't do it very often. I could go off on a tangent there, but it's so important to take care of yourself when you're dealing with infants. Okay, there's that 3 to 1, 120 per minute, which that would equate to 90 compressions, 30 ventilations. Hands-only CPR is not affected as ventilation with CPR in the neonate. And we throw that bullet point in there because you've probably been told, and rightfully so, that if I've got an adult in cardiac arrest, if all I do is just hands-only CPR, it's probably good enough. Probably actually better than trying to ventilate, because when you try to ventilate, you're reluctant to do mouth-to-mouth. You're reluctant. You pause too long to get a good seal if you're using a back valve mask. There's no compressions going on at that time, which is a bad thing. Hands-only CPR does not apply to the neonate. Frank, to your point, what I want out of this is that ventilation, don't I? I want that ventilation. And should the ventilation have already been there before you started chest compressions? So you're really not adding ventilations, you're adding the compressions to something you were already doing. Are you with me on that? So if I back out and I stop the chest compressions, then I would keep doing what? The ventilations. And then I would pull those off and keep doing what? Ensuring that they're warm and dry.
What would be the age gap between like a neonate and a child when you would switch it?
Newly born.
Just newly born?
The jury's out on that. You could read 5 sources and get 5 answers. I like the 30 minutes of life. I like the 30 minutes of life. Some people say the first 24 hours. So I think for your definition, I would go with 24 hours. To me, though, that's a little long. I'm not playing in this world for 24 hours. But I think by definition, you should probably go with 24 hours.
So after 24 hours, then it's 30 to 2?
And the reason I say that, Starrett, yeah, the reason I say that, I'm not even at the 5-minute mark for the next APGAR score. So that's why I tend to say this 3 to 1 ratio is right here, right now, newly born. We're not dealing with this 12 hours later. At the 12-hour mark, they should have been fed, they should have been stabilized, and if they go into something else, I'll address that at that moment. Let me say it another way. I hope the hell I'm not in this at the 12-hour mark.
Yeah.
We're missing something. We'll practice this again tomorrow because I'm not real sure you've practiced a neonatal resuscitation at 3 to 1 ratios. And so we kind of need to just go ahead and do that just to see 1, 2, 3, puff, 1, 2, 3, puff, 1, 2, 3, puff. It's different than a toddler or a one-handed on a small child. Well, it's certainly different in 2 hands and the 30 to 2 thing. if meconium is present and the newborn is not breathing. Gus, read that one more time.
If meconium is present and the newborn is not breathing.
Did y'all hear him? If meconium is present and the newborn is not breathing, take appropriate action. What do you think that action is?
Hospital.
Hospital? Huh? Suction. Suction. If they haven't taken a breath yet, it's a really good idea to get the poop out of the mouth and out of the nose. Okay, Gus, you said if it's present and not breathing. What if it's present and they are breathing?
Well, I just don't want to get out of there. But maybe not suction, just use normal.
We didn't get in the hospital.
Well, that would have said, Sterrett, to your point, that would have read, if meconium is present, they'd have left all this off.
Yeah, I guess you're right.
In other words, if I've got a breathing baby, applaud yourself. Be happy. Meconium present, meconium present. Do not drag the baby back down this bad road trying to get the airway all cleaned up. As a paramedic, I was trained and taught to, hey, if meconium is present, intubate the baby. Put the little tube in there. They make a device that will hook your suction unit to the ET tube. Kind of see where we're going wrong here? Hook your suction unit to the ET tube and pull the ET tube back out while suctioning. Clean up, do it again. Hook your suction unit to the ET tube and pull it out. We've got to get the meconium out of the airway. What am I doing when I intubate, pull out, re-intubate, pull out, re-intubate, pull out? I'm irritating. So I'm driving them into bradycardia. I'm tearing tissue, causing trauma in the back of the throat. I am blocking the airway. I am maybe pushing stuff down instead of pulling stuff out. I am not letting them breathe, deflating the lungs, pulling out the oxygen, causing hypoxia. Hell, I'm giving myself this nice code to work. Those devices are called meconium aspirators. Some ambulances still have them on there. I can still do that. When, Sterrett?
They're not breathing.
If they're not breathing already. But if they're already breathing, it's already there. If the patient is breathing, if the kid is breathing, go ahead and suction as you normally would anyway to clear an airway. Just don't get all stupid about it because there's meconium. They're already breathing. It's already there. Billy, I think it was you. Where are they going to go? Where's this kid going to go anyway? Hospital. What type of hospital? Yeah, something that's got a NICU or a neonatal intensive care in it. They're going to go ahead and start antibiotics anyway. They're going to see a neonatal pulmonary specialist, if you will, a pulmonologist. So if they're already breathing, it's kind of like, well, the damage is already done if there is any damage done. Don't cause damage by getting overly aggressive with suctioning. Gus, that makes sense to you now after you read it? Sterrett, you kind of clear now on what we mean by that? Luke? Meconium, yeah, usually green or yellow. Pasty. Where did you find this at? When did you discover it? No, I mean, when did you discover it if you were working this kid, when would you discover meconium staining? Huh? Or maybe during the delivery, when the water broke and it stunk and it looked like pea soup and it wasn't clear, it was cloudy and green and yellow and pussy. And I'll just go ahead and say it, somebody shit in the bowl of soup, okay? Right? It's like, that's not right. That's meconium staining. Is it a sign of a potentially distressed neonate? If the birthing process was hard, sometimes the kids just poop. If they're past term, they might have pooped because they just needed to, because it's been a while. But usually they don't poop until they suckle and get something else inside them. Here's your APGAR scoring. Remember, we're going to do this at 1 minute and 5 minutes. Brandon, I wish you'd have told me this before we started resuscitation. No, you don't. I don't want you on scene to worry about a scoring system taking priority over a resuscitative effort. Are we clear on this? Most of these APGAR scores are done retrospectively. And I'm 100% okay with that. If somebody gets on to you for not taking an APGAR score at 1 minute when you were doing 3-to-1 chest compressions to ventilations, I applaud you and I'm going to shame them. That tells me I looked at a situation and realized it needed work, not just something to fill in paperwork with. Should we do APGAR scoring? Sure. Should we do it instinctively, not running down a chart, just looking at them and going, that's bad and I need to address it? That's how I want you to do it. So we get a number value to 5 areas. I'll go ahead and tell you the top score in each area is 2. So 2 times 5 is 10. Or 2 added to itself 5 times is 10. So what's a perfect score? 10. 10. How many babies are born at a 10? Like coming out of the womb at a 10? Doesn't happen. Doesn't happen. I'm not saying it can't happen. I'm just saying it doesn't happen. So don't expect a 10 on the way out. When should I expect a 10? 5 minute mark would be awesome. If I'm improving from where I was, but still not at a 10 at the 5 minute mark, still awesome. I'd like to have a 10 before the first birthday, all right? Before they blew out their first candle or got their first tooth, I'd like to have a 10. I'm just telling you, some kids are so sick that they don't ever make a 10. But this only applies for the newly born, so we don't have to worry about that anyway. Perfect score is 10, 1 minute, 5 minutes, already been through that. Here is the scoring system. Ding, ding. I would not be surprised if the registry, or maybe even me, was to ask you a question, give you a patient condition, and you calculate the APGAR score. So let's look at it. Appearance. Is the newborn pink everywhere? We'll give them a 2. If the body is pink but the hands and feet remain blue, we'll give them a 1. We have a name for that. So like the hands and feet are blue but the body's pink, that's called acrocyanosis. A-C-R-O cyanosis. Acrocyanosis. That's kind of trivial at your level right here. I wouldn't worry about having to memorize that definition, but we do have a name for it. I would expect this on a newborn. I would expect the hands and feet to be blue. If the entire baby is blue, they get a 0. What's the worst score I could get overall? 0. Best score I can get? 10. All right. Pulse, more than 100, give them a 2. Less than 100, give them a 1. No pulse, 0. Grimace or irritability. I think Virginia APGAR used the word grimace so it would fit her last name. Virginia APGAR was an obstetrician who developed this scoring system to fit her last name. So I think she came up with the word grimace to fit there. One of these days, Billy, I want you to come up with something so we can teach about it and EMS training, okay? Don't you be one of those leaders out there. It's the Billy method. Everybody knows what the Billy method is. Billy was this EMT student from Denison, Texas back in 2024. Cries and tries to move foot away from finger snapped or against sole of foot. So this baby has reflexes in him. We'll talk about reflexes in our next chapter. The Babinski reflex, the Palmer grasp, the suckling reflex. If the kid's got reflexes and he's crying, flailing about, he gets a 2. Weak cry in response to a stimulus, like he whimpers when you tactily stimulate him, but otherwise he kind of goes limp. It's a 1. No reaction to stimulus, it's a 0. Activity or muscle tone. You try to straighten, they want to curl up in what we call the fetal position. Y'all have all heard of the fetal position, but you try to pull their legs down and they resist. They want to pull them back up. That's good. You're fighting me. You're mad. I give them a 2. Resist, 1. No muscle tone, 0. Limp. And then respirations is the last one. They breathing fast or crying, 2. Whimpering, no crying, or very slow, 1. And no respiration, 0. It sucks to deliver a baby that's a 0. It sucks to deliver a baby that's a 0. You've got to attack it. When I say attack it, you know what I'm meaning at there. Attack. Go for it. Warm them, dry them, ventilate them, chest compressions. See if that's working. If it's not working, drugs, oxygen, epinephrine, that's an ALS line. Back out of it as they improve. Very few come out as a 10. No problems there. I was actually looking for an answer on here. The answer I'm looking for, let me see if it's in your textbook right quick. What's an acceptable APGAR?
6, 7.
6, 7? Is that in your book?
I don't know.
I said it yesterday. Yeah, I did, and 6 or 7 is what's sticking in my head. If anyone wants to Google that, I will not mind. That 1 minute APGAR, I think 7 is good. Probably depending on your source.
Google said 7 to 10.
Who does? Google? Google who? Who Google? American Academy of Pediatrics or
HealthyChildren.org.
HealthyChildren.org. Well, we got to go with them, don't we? All right, here it is. Page 1269 from your textbook. Right-hand column. The highest possible score is 10. Should be calculated 1 in 5 minutes. Should not delay resuscitation and is generally deferred. Even the book agrees there. A score of 7 or higher is considered reassuring. 7 or higher is considered reassuring. So I was right. Damn it. Questions on that? It's a good breaking point, so I'm going to give you a break a little early today. Any questions on that? We're closing this chapter out. You think you could calculate an APGAR for me now that I've given you the parameters? If I'm thinking correctly, if my mindset's right, I think the National Registry would be more on the concept of less trivia, more application, especially if you're doing well on the test already. And they say your baby is born at the 1 minute mark, the APGAR is 5. You should probably ensure You finish the sentence for me. What should you ensure if the APGAR is 5 at 1 minute? Airway,
Pulse, airway.
warm, dry, warm, dry. Just start that triangle, warm, dry. If they're a 5 at the 5 minute mark, what are you probably doing now? ALS, BVM use, maybe compressions. You kind of getting the point? So if I give you an APGAR, if they're a 9 at the 5 minute mark, what should you be doing? Monitoring and transport, right? Yeah. You kind of get where I'm going with those questions if I ask them that way. And there's more application in that than there is, I'm going to give you this set of perimeters and you match it to a chart. That's just an exercise in memorization. That's a low level question, by the way. I'd rather you apply something at a high level. Your newly born infant is at a 0 at the 5 minute mark. Action should include